The following webinar was recorded as part of the original implementation of IWISH and has been made available for informational purposes only. Some portions of the original recording have been cut to ensure participants' privacy. References to the Lewin Group, implementation team, site liaisons, PHL, Google Drive, and some forms are not applicable to the demonstration extension effective October 1st, 2020. Terms and conditions of grantee's cooperative agreement supersede any information presented here. Please see the IWISH Operations Manual for the most up-to-date implementation information.
All right, we are going to go ahead and get started. I see we have a lot of people joining us today, and a couple of people are coming in. So glad that you all are able to join us. I know that it's been a while since we've had one of these amazing IWISH trainings, but don't worry, this is going to be a great one and definitely one that is relevant and timely as you all continue your enrollment process. Since it has been a while since we've had one of our trainings, I want to remind you of a couple of logistics. One, these are all designed to be engaging trainings. We definitely want to hear from you. We want to hear your questions, your thoughts, your reactions to what you're hearing. So please click the chat icon in the upper right-hand corner if you ever want to respond to what you hear today or if you have a question. Then remember also that at the end when we have Q&A that you can use your phone to ask your questions. So you'll just need to raise your hand and we'll unmute your line so that way we can hear from you. If you have any technical challenges, maybe you can't hear us anymore, your screen freezes, or there's some type of technical problems that you experience, remember to select all panelists and answer and send your question. And then if it's a general...
You also have a more complete picture of the participant because of the assessment in the PCI that you all are doing right now, or hopefully you're doing. And you'll be in the home setting and building those solid relationships throughout the IWISH demonstration. And you will know how the participant acts on a day-to-day basis, and you may recognize small changes that other people in the healthcare settings would miss. And I remember the frustration when I worked in the hospital at trying to put together the medication list, knowing it might not be comprehensive or just wrong, because sometimes, the person forgets the name or how often they take it, they describe what the pill looks like, and just they're sick when they're in the hospital. When I was a transition coach, and saw people after being in the hospital and was in the person's home, it made me realize the disservice we do by not having a good system that allows a true opportunity to do a med rec. And I got to see the bags full of medication, half full pill bottles, prescriptions for this, 2 beta blockers, but maybe they had different names, the supplements, the unnecessary medications, and how overwhelming managing medications can be to someone. And so as a wellness nurse or resident wellness director, you can be a key support to the participant and healthcare team in the medication management process. And I hope through this webinar today that you'll really learn your key role in this process and some tools that we have available for you. Mike?
Well, thank you for the introduction. Again, I'd like to share with the group that this is near and dear to my heart, and the opportunity I can to share wisdom around medication management and how to best do that as supportive staff as part of this project. Hopefully we can get some good things taken care of today, and I can give you some guidance as to how to best approach that in your role as the wellness nurse or the resident wellness director. Let's go through and see what we're going to accomplish today. There's 4 main objectives that I'd like to accomplish today. One is to get a sense to help you recognize what some of the common problems that we see in practice. And I think most of you could probably share with those, and hopefully you'll bring up some ideas today of things you're seeing actually in the field right now. And I think with the introduction, you heard a lot of challenges around medication problems. We're going to talk a little bit about the intake, the value of your comprehensive intake and your assessment, and the role medications play across that entire assessment, just to help you realize that every little piece of that intake and that intake assessment really correlates and integrates with medications. And there's subtle things you could pick up on that assessment that play a role in how you might guide that resident. And then we'll really spend a bulk of our time looking at the best practices based on medication reconciliation and medication management principles, and how you as a resident wellness director or wellness nurse can actually intervene, actually be part of the process, and assist with the healthcare team in navigating that process and optimizing that process for the client. And then lastly, I'll provide you with some resources. So we can move on. So 3 fundamental principles that I want to share with you, and the first being polypharmacy. So first and foremost, one of the biggest challenges we have as people age, as people get older, they become more frail, they have more health conditions, ultimately we layer on medications. And I was provided with a kind of an Excel spreadsheet of the typical pattern of medications that your seniors are on through the project right now. And clearly, there's lots of patients and lots of people, I should say, on lots of medications. And, some of them are on 2 or 3 medicines, some are on 11, 12, 13, 14 medicines. But clearly, multiple medications are being used for multiple medical conditions. And this is our biggest challenge. So once patients get on 5 or more chronic medications, the risk of adverse events and the risk of drug interactions go up exponentially. And so the pattern that we typically see in the United States follows this pattern. 36% are on 5 or more chronic meds. 20% of those are estimated to be inappropriate. So I could look at the pattern of meds that I've seen coming in already based on what was provided to me, and as a pharmacist, as a healthcare provider, as a wellness nurse, you could see that that's a complex regimen with multiple medications, and I see lots of medications that are potentially inappropriate. Now, your role isn't whether to say that it's appropriate or not, but certainly recognize that polypharmacy poses considerable risk. And once we get on 5 or more meds, chances are the risk of a drug interaction goes up exponentially, and the risk of an adverse drug reaction goes up exponentially, to the point where about 1 in 5 admissions to the hospital that we see across the country here today are really a result of a medication misadventure, whether that's overuse of a medicine, underuse of a medicine, inappropriately taking that medicine, too many medicines with combined drug interaction risk. They end up in the emergency room because of that risk. Think about that. 1 in every 5 admissions for older adults are because of a medication misadventure. Oftentimes, clients aren't really honest and open with their provider, believe it or not. They're not asking the right questions. They're not being honest with their adherence measures when they go to see the doctor. They're not sharing with them whether they're taking herbal supplements, complementary medicine, alternative medicines. So one of the things I noticed on the intake form is I noticed a lot of prescriptions and a lot of over-the-counter medicines listed, but I didn't see many herbal products or other supplements listed in the medication list. So again, an area where you could be of tremendous value on the intake. It's estimated that 40% of patients over the age of 65 take some sort of supplement or herbal product. And I'm not seeing those on the intake, so maybe we're not actually picking up on that, or maybe we should be more thoughtful when we ask about all medicines, because a lot of seniors don't feel like over-the-counter medicines are actually medicines. And so the point that I want to resonate with the group here today is polypharmacy is common. It creates lots of problems. It poses tremendous risk. Well, let's talk about that risk. Next slide. So here's our dilemma. Our dilemma is that when we have older adults with multiple problems, they typically are on multiple medications. They're seen by multiple different doctors. It's a very fragmented system. No one's looking at the whole patient. Everyone's treating their organ system. And so when all of a sudden these medicines get combined with the underlying conditions, remember I said 1 out of every 5 of those patients tends to show up in the emergency room or our hospitals with a medication misadventure. So there's an increased risk of hospitalization, increased length of stay when they are in the hospital, increased morbidity and mortality, increased recidivism or readmission, and then what we call geriatric syndromes. So they can get dementia, delirium, depression, incontinence, increased risk of falls, all these syndromes that we see in older adults. These are real. The data supports the fact that polypharmacy, multiple chronic conditions, higher risk of adverse events, drug interactions leading to high utilization of our healthcare system. This is actually the goal. This is what we're trying to prevent. We're trying to slow, diminish, delay healthcare utilization visits. Can we keep someone functional, active, and engaged at home in their residence as long as possible, and utilizing the healthcare system in a way at the lower utilization pattern in terms of cost to prevent those hospitalizations, prevent those emergency room visits. And so ultimately, the bedrock of polypharmacy creates the biggest problem, and it's the number of drugs that are the biggest risk and the biggest predictor of harm. And you as a wellness nurse and a resident wellness director could easily at the intake look at that and say, wow, this person's on a lot of medicines. Maybe we need to stay a little bit more focused on the role those medicines play in their overall care. Is that line of communication with the provider going well? Are they active? Are they engaged? Are they being honest and forthright with their healthcare provider and prescriber? And do you identify anything that you think is a red alert or a red flag that might be a concern, and how do we notify the system in a thoughtful way to prevent this high healthcare utilization process? So let's go on and say, well, what are some of the common symptoms that we typically see in practice? Next slide. So this is how it plays out in practice for us. So you're working with an older adult in the community and their residence. They're comfortable in that residence. They're picking and choosing how they take care of themselves. They're picking and choosing the medicines they take. They may or may not be taking them appropriately. They may or may not be adhering to them. In some situations, we may think they may be underutilizing them, or they can't utilize them, or they're overutilizing them. Ultimately, a lot of times this ends up in a medication misadventure, an adverse event. And the key here is that risk associated with that medicine perceived as another problem? And so what I did is I said this is a very complicated road, right? Where someone's fatigued, they're weak, they're more confused, something's different, or they've had a couple falls in the last few weeks. They seem like they're more confused, they're more disoriented. And these are things we typically associate with frailty, older adults with multiple chronic conditions, but yet what I'm trying to impress upon you is that a lot of times these general symptoms, these general behavior changes, these general things that you identify of a senior that just doesn't seem right, something's changed, something's different. These types of symptoms are often a manifestation of a drug misadventure or an adverse drug event to a medication. So for instance, there's numerous classes of compounds that increase the risk of falls. We could be treating someone's blood pressure and we're treating it too aggressively and their blood pressures are too low and they have orthostatic hypotension. And that's actually because we're actually over-treating their blood pressure. Or they may get dizzy because they're on 3 or 4 medicines that cross the blood-brain barrier and are making them more confused. We had an admission to the hospital today of someone an older adult in their 80s, who was very confused, very disoriented, and they were on 5 medicines that all worked in the brain. And so some of them were over the counter, some of them were prescribed, but again, it ultimately led us to actually think through those medicines and actually hold and stop some of those medicines because they may have been contributing to the disorientation, the dizziness, the confusion, what was presented. So as a wellness director or a wellness nurse, you're in a keen position to be right in the trenches and know whether that client is off a little bit today, they don't seem right, something doesn't seem right, and how could I help? And so as a surrogate healthcare provider, you're the eyes and the ears and you're the voice and the advocate for the client or the older adult, and the communication of that up the ladder to the appropriate healthcare team member to try and keep that person as active and engaged in the home versus impacting the healthcare system. Next slide. So what I'd like to do is hear from you. Have you seen some of this? Again, I've seen the medication lists that have been coming in while working with the clients in the community. Are you seeing some of these things that you might perceive as an adverse event or a medication-related problem? Would you like to share that with us today and comment on that?
You can enter your thoughts via chat, or if you raise your hand, we'll unmute your line. And I know that some of you all, while doing your enrollment and learning from residents, you probably actually have already had a situation like this where you have had to talk to a resident about a new symptom that they have. So tell us, how would you approach it, or how have you approached an older adult with a new symptom? So Lisa says, yes, and family or friends of the resident setting up pill boxes with wrong meds and the wrong time. So how have you approached that situation, Lisa? And Lisa, feel free to raise your hand so we can unmute your line. Lisa says, we cannot intervene except to advise and educate. So you would approach with the intent to advise them and educate them on their new symptom and the medications they would take. Is that what I'm hearing, Lisa? Yes. All right. Thanks, Lisa. Emily, it looks like Judith has raised her hand. Will you unmute her? We'll hear from Judith, and then I'll turn it back over to you, Mike, to continue.
Sure.
Judith, your line should be unmuted. Oh.
Hello? Hello?
Hi, Mike. Sorry. It looks like Judith put her information in chat. She says, considering multiple chronic conditions related to the aging process, I always ask if they have a new drug in their list and explain about the secondary effects.
Okay, those are excellent, excellent thoughts, and I'll comment on both of those. Again, the concept of multiple chronic conditions in the aging process, actually asking that person if a new medicine has been added, a new medicine has been taken away, are excellent questions to ask. And a lot of times this occurs during times of transitions, and we'll talk more about that in a little bit. And then regarding the pill box explanation and the family support system, where they may actually be setting up pill boxes to help the patient but setting them up wrong, both of these really speak to what the big challenge in our healthcare system is how do we obtain this best master medication list that's real-time and autonomous, and everyone knows exactly what medicines the patient's taking. Because in our system it's very fragmented, and we go in and out of the system through appointments, through multiple doctors, the emergency room, the hospital, transitions, and during these transitions the medications may get changed. And so two key points here. What is that optimal best medication list? Who controls that master list? who knows what everyone's really taking, and how do we manage that in terms of day-to-day function with pill boxes and making sure they're accurate, and so we can do that by engaging the patient and her family or caregivers and saying during times of transitions, it's very important that we understand what medicines you're taking, what medicines you're on. We want to make sure you have the best list. So when you've identified something where the pill boxes may have been the medicines may have been incorrectly put in, that's a great chance for you to engage with the up the ladder and make sure that list is accurate, okay? And you can encourage the patient or family to call the doctor to make sure and vet that list to make sure it's accurate. Or you could certainly, if there's any confusion around a medicine, if you identified that when asking if a new medicine has been added, you could then advise and educate during that time. So 2 great examples, and thank you for sharing those. Why don't we move on to the next slide, please? So this is a real important slide that I want to share with you, and I'll walk you through that. So we talked about polypharmacy being a challenge, multiple chronic conditions, multiple meds, and the potential for risk. This is the prescribing and the medication monitoring process, and it's important to understand that a doctor is going to see a sign or a symptom or a new diagnosis and potentially prescribe. So if you go to the green box on the left, what we're trying to do is make sure that we're not prescribing a new drug around a new symptom. And so it's very important that the doctor's aware of the whole medication list and the possibility that those medication lists could actually create some of those symptoms. So encouraging the patient and the family to have a master list, carry that list with them, bring that list with them to the doctor, and actually bringing the bottles and everything, and the inhalers and the eye drops and everything along with them to every visit, so those meds can be reconciled at that healthcare visit. The second green box, which is embedded in the red box overall, the important thing that I wanted to portray here is that when we use a medication, prescribing is one component, but monitoring that drug is actually the larger component. And educating the patient, the family, and the support system, and activating them to understand what those medicines are for, to understand the importance of taking them, and what to look for if there's problems, and to consider that some of these effects might actually be a side effect of a drug if you have a new symptom. And so again, this is part of the prescribing process, but the monitoring phase is part of education and activation where you play a key role. So I want you to understand that although you might not be making the decisions and the recommendations and prescribing a drug, you can be very keen and very alert to activating and educating the patient around that medicine and making sure they're comfortable and adhering to that medicine as prescribed. So you're part of that process. Next slide, please. So from a medication management standpoint, when we look at the healthcare team, we're really looking at the patient being the center of medication management, and how do we interface with that patient around the process of assessing that client as part of your assessment, checking those medicines and making sure those medicines is a master list for them, and that's part of the intake. How do we optimize those in terms of ensuring adherence and educating and activating that patient to take those as prescribed? And then how do we follow up if we identify a problem and interface? So what we'll do now is move on a little bit to the second bullet point, which is the part of the assessment and all the key variables that you need to take into account. Next slide, please. So let's take a closer look at the key medication intakes and part of your assessment. Next slide. Okay. Your medication assessment is this long intake list, and what I wanted to impress upon you is that there's numerous things in that intake that are absolutely critical to medication management. First and foremost, the role immunizations play, right? So immunizations have a critical role in delaying and preventing and minimizing vaccine-related diseases. And so the intake of vaccines is critical. You might identify barriers to vaccines, people who choose not to get vaccines, so you need to educate them and activate them to get over the myths of vaccines. They're one of the few medicines we have that actually can eliminate and eradicate conditions and minimize the risk of getting those conditions. Still today, we have close to 50,000 people a year that die of vaccine-related diseases, and vaccines could help prevent that. I did want to make one specific recommendation here around the zoster shot and shingles. There's now a new shingles shot available, and so part of your intake, one of those intakes is the shingles vaccine. There's a new one called Shingrix, and this is now advocated that everyone should be getting the Shingrix shot. So even if they've had a shingles vaccine, they now need the new one, and this just came out recently. So again, another way that you could activate and engage. You're getting a master medication list and master allergy list, which is critical that patients are aware of their allergies and aware of their master medication list. One of the things that I would encourage here with the medication list is trying to link that list with the diseases that they have. So if they have a medicine and they're taking a medicine called pioglitazone, does that older adult realize that pioglitazone is for their diabetes? Or if they're taking a drug called donepezil, do they realize that's for cognitive dementia? If they're taking an inhaler, do they realize that's for their COPD? Linking a drug to an indication is probably the best thing you can do to educate and activate a senior, because if they don't know what it's for, you've identified a gap in education. And I can tell you, we see this all the time where someone's on 12 medicines and they really don't know what they're taking them for. So again, linking that medication list to indications is critical. During that time, you could assess assistance and gaps in insurance. So there's specific questions in your intake that deal with, do you have problems affording your medicines? Do you ever go without your medicines because you can't afford those? Those are key questions that link to whether they could adhere to their meds and access their medicine. You perform ADLs and IADL screens. And again, here, medication taking behavior is actually an instrumental activity of daily living. So you could identify gaps in adherence and gaps in understanding and gaps in medication taking behavior in your screening for IADLs, in addition to these specific healthcare questions. You're screening for substance use such as alcohol, anxiety, depression screens, falls. All these screens correlate with medications. There's a component of depression and anxiety that may lead to undertreatment of a symptom, or overtreatment, or misuse of a medication that potentially adds complexity to the regimen. And as you begin to treat depression, dementia, delirium, anxiety, and you're using these medicines, they're all CNS medicines, or medicines that work in the brain. And what studies tell us is that when patients are on 2 or more medicines that cross the blood-brain barrier that are used to treat a condition such as depression, anxiety, dementia, insomnia, that you're at increased risk of falls. Okay? So now all of a sudden you're starting to get a pattern. Do we have gaps in immunizations? Do we have gaps in understanding because the medication list, the patient doesn't know what they're for? Do they realize that there's a new vaccine out? Do they understand that medication taking behavior is a functional component of an IADL? Do we realize that the more CNS medicines you're on, the more likely you're at increased risk of falls? And there's 2 subtle things that I want to talk about here, is diabetes and blood pressure. Very common in the older adult population. And what we found in the last 5 to 10 years, our aggressive management of those conditions in the older adult has become more liberal. So what we've shown is that we can't set the same pattern for diabetes treatment or blood pressure treatment in an 80-year-old as we can for a 50-year-old. So what I've seen is we've seen overtreatment of blood pressure and overtreatment of diabetes as causing an increased risk for healthcare utilization. So now all of a sudden you're seeing this pattern of this patient that's all patient-centered or client-centered or participant-centered, and working with them, you could identify their gaps in knowledge, their gaps in education, their inability to be activated, the impact medicines could have on function, ADLs, IDLs, the impact medicines could have on cognition, the potential to increase the risk of falls. So all of a sudden, medicines are permeated through this entire intake that you have, okay? And what I want to stress to you it's really all about what I call the 4 A's. Okay, how does that person access that medicine? Could they access that medicine? Do they have gaps in that in doing that because of insurance? How do they adhere to that medicine? Are they having any adverse events to that medicine? And is that appropriate? Now, again, I'm not asking you to say make a decision whether that drug is appropriate or not, but be aware of some of the things I just told you. If they're having hypoglycemic episodes, or if they have orthostatic hypotension, or if they're on lots of medicines that cross the blood-brain barrier, chances are that degree of prescribing is polypharmacy that has a potential detrimental effect. And I'll give you some resources that can kind of guide you as to those higher risk medicines, called the Beers criteria. Okay? And from a medical standpoint, we try to stabilize the patient on the fewest amount of medicines at the lowest doses possible to optimize their therapy in the context of their complex, multiple fragmented system that they typically are in terms of care. So again, I want you to appreciate that intake is invaluable and that medicines permeate that entire assessment, and you should pick up on some of these things throughout the domains to consider some of the challenges there. And what I want to leave you with is that I really think you could have a huge impact on access, adherence, and identifying adverse events, and the role of educating and activating the patient and or the family, the client and their family, I should say. Next slide. So again, the 3 lighter blue target areas, access, adherence, and adverse events, are the 3 areas that I think the wellness nurse, the resident wellness director could play a key role, and even appropriateness in the context of some of the symptoms you're seeing. It's not your decision to make whether it's appropriate or not, but if you identify something that doesn't seem right, bring it to somebody's attention. And chances are, if you have a hunch, it's a good hunch. You know, they're on 15 medicines, but they're really only taking 3, but they seem to be doing fine. Chances are they're on too many medicines. Maybe you should have those medicines reviewed, bring all those to your next clinic visit, and have those reviewed. And again, my goal as a healthcare provider is to have the participant on as few as medicines as possible, consistent with their goals and what they want to achieve, and be on the lookout for any treatment that you think might not have a clear benefit. And so patients are on pain medicines, they've been constipated for months, and they're on nothing to loosen their bowels, or they're having diarrhea, and they're on laxatives. That doesn't make sense. You might want to suggest that, well, if you're having diarrhea for multiple days in a row and you're on laxatives, you might want to consider stopping those. So you might want to touch base with your doctor and reach out to them and go over your list and make sure it's the right medicines for you at this time.
Hi, Mike. This is Alicia. I just wanted to I'm just keeping an eye on the time for you, and thought maybe you might want to we can hold the questions that are still out there, and we can pick those back up to help you move along.
That'd be wonderful. Thank you.
Okay, great.
Great question. So what I've done now is what I want to move to is best practices. So from my standpoint, every situation is going to be unique. Every situation you encounter is going to be unique. What I tried to do is try and reinforce that I think a huge role for the wellness nurse and the resident wellness director is to try and identify and observe patterns in the patient's medication access, gaps in adherence, gaps in, identify adverse events that could be drug related. Let's look at some of the things that I would consider best practices of things you could put in place and things to consider. Next slide, please. So I'm going to actually go through about, what I'm going to go through is about 10 different areas that I think are critical. So one is identifying and assessing adherence. I think as a wellness nurse and a resident wellness director, you could identify adherence issues. And I think you should have medication adherence and consider that a vital sign. Much like you take blood pressure, much like you take temperature, you should be assessing adherence. You gave the example, Alejandra, that the medication adherence in this patient was potentially inappropriate. They were cherry-picking meds and hanging on to medicines and not being honest and forthright with their doctor. what you did is you took the next step and informed the healthcare team, and that's an important step. When you see someone who's got medications that they're confused with, medications that you may assess adherence problems with, you should encourage them to bring all their medicines and ask for a med review. So this is where the physician or a physician assistant or a nurse practitioner or a pharmacist may get involved. You know, you'd really benefit from a medication review to make sure all your medicines are the best medicine for you at this time. Everyone under Medicare and anyone under Part D benefits, ultimately medication reviews are part of that process, and they're paid for annually to do that. You should actually, as we alluded to before, someone mentioned during transitions of care, 50% of all problems with medication taking behavior occur during that transition. You should always encourage a medication master list and adherence aids, whether those be pill boxes. Now I know we had a comment earlier that someone was filling the pill boxes wrong. So pill boxes are only good if they're filled appropriately. So if that person needs assistance with those and the family or caregivers can help, that's wonderful. If you as a wellness nurse can help, wonderful. And then you could also just peripherally examine prescription containers and look for refill information. Are they carrying a medicine? Do they have 3 bottles of the same medicine? Or like you alluded to, I saw someone taking medicine that they were taking previously and it stopped and now they're still taking that. So just observing the containers, observing the refills, consider age, adherence age, consider transitions being vital, and always raising the level of scrutiny. So you could say, I think this is a concern. I think you should have your medicines reviewed by your doctor and have a complete medication review. And again, this is what we're trying to do, is promote these comprehensive medication management reviews, and they're actually covered by insurance in many cases. Then I've given you some typical questions that how you would introduce those types of things. Next slide. One of the other areas, the next area that I think you could be involved in is terms of optimizing therapies. And again, you're not in the business of prescribing and making recommendations. You're just reviewing those medicines and reconciling those medicines and making sure if the practice is safe. So the practice of taking medicines that have been previously stopped is not a safe practice. It's potentially inappropriate. So you've identified that and you're bringing it to someone's attention. You could evaluate the medications when you're counseling a patient or you're educating them on if they're confused about their medicines. They think this, you know, they're on this drug and they thought it was for pain, but they're taking it for something else. They decided not to take that medicine because they don't think they need that. So you've identified areas where the therapy is not optimal. When you see medicines that, if someone's on 5 medicines for diabetes, maybe that might be too many. Might you want to bring that to someone else's attention and then bring it to a nurse practitioner's attention or the PA or the pharmacist's attention? And always advocate for the participant's goals. And so when you see complex regimens with 6, 8, 10, 12, 14 medicines, ask about what their attitude towards medicine is, their aptitude. Do they even feel comfortable taking these medicines? If you could be on less medicines, would you want less medicines? So I think an example we were talking about last week in the prep for this was a patient who ultimately, she was taking her medicines, but she really didn't want to be on it. So the doctor prescribed it, but she decided not to take it. So that's a breakdown in communication, a breakdown in trust, and she wasn't being forthright with her goals and preferences for her care. So I think it's very important that you help empower and activate the participant to be more, to ask more questions at the point of prescribing, not just, oh, whatever the doctor says. Because if they say, well, I really don't want to be on medicines, or I'm confused with all these medicines, I'd prefer to take less medicines, this is something that the provider and the prescriber should take into account. Next slide, please. Another big area where I think that the wellness nurse and the resident wellness director could help is just help participants remember. When you identify someone that has very complex regimens, they're on a lot of regimens, again, challenge them to get A medication review, try and minimize those medicines. Boy, you're on a lot of medicines. It must be difficult to take those medicines regularly. What do you do to help you remember? Show me how you take your medicines. Oh, I see you're on an inhaler. Can you show me and demonstrate how you actually take that? And so you could be very instrumental in helping to try and strategize ways to how these medicines could be taken and adhered to according to how they're prescribed in the context of their daily activities, and strongly encourage the help of family, friends, and trusted individuals when and if available. So again, giving you ideas of the way you could approach that, how you could open the dialogue with questions. Next situation. We talked a little bit about access and adherence to medicine. So you could be instrumental in terms of addressing financial and physical barriers to education. So a lot of times when people have difficulty getting to and from the pharmacy, we could encourage medication delivery, mail order processes. We could help with transportation. We could identify barriers to access at these points of care transitions, like the example we alluded to earlier. They were transitioned out of a hospital and it was 3 o'clock in the afternoon. They didn't have access to their meds. How do we facilitate that transition? How do we communicate with someone to help identify how those medicines can be accessed, how they could be retrieved in a timely manner to minimize the problems around that care transition? A lot of times eye drops, inhalers, certain types of formulations, injections are hard for someone to give with limited mobility, hearing difficulties, sensory impairment, vision impairment. You could help with those types of things. If a patient says, well, I can't afford this medicine, it's $1,000 or $500, we could certainly call and communicate with the healthcare team and say maybe it's not covered under their formulary. There might be lower cost options. You could help with access that way, looking for free or low cost medications. There's other things that you could consider. Tablet splitting and 90-day refills reduce costs. So if someone's getting medicines every 30 days, we could try and encourage 90-day delivery. Sometimes there's doses that could be split, and we could save half the money by splitting that tablet. Again, things to encourage. And if you identify access issues or adherence issues due to physical barriers, raise those to the next level. Say, I've identified something that's concerning. I could try and help with this, but next time you go to the doctor, make sure they're aware. You bring all your medicines and make sure they're aware that you're having difficulty paying for these or you're having difficulty using this inhaler. Oftentimes when we go and do home visits for older adults, we see that they've got multiple inhalers. It's confusing. They don't know which one to use, how to use it. And so these are very good ways that you could help. Next slide. And I'll go through about 4 or 5 more areas and then we'll open it up for conversation again. So in educating participants, I think this is one of the biggest roles, right? So how could you make sure, well, we can go back to communication here. So there's 2 things here. One is education and communication. So how do you communicate effectively with the participants? Again, open-ended questions. Can you tell me a little about why you take each medicine? And again, if there's gaps in their knowledge of why they take it, you could begin to help them understand why it's so important to carry that master list, understand what that medicine is actually taken for, matching that drug up with a condition that they have. Ask a patient about their beliefs in medicines. A lot of times their attitude or their ancestry or their culture and their belief system is one that they don't want to take prescription medicines. They just want to take supplements and herbal products. And again, herbal products, OTCs, and supplements have a potential role as alternative and complementary medicines, but they have to understand that if a doctor is prescribing a prescription drug, the value of that prescription drug, and how do you communicate with the provider that you're taking supplements and herbal products and you may or may not want a prescription medication. So very helpful here by just asking a patient, can you tell me a little bit more about why you take this supplement, why you take this herb? What do you think you're getting benefit from? What do you understand the benefits are and the risks? Would you know where to get information, more information about that? And I'll give you some information towards the end here. Next slide. You should provide materials to them in a written form in multiple languages. So I overheard some of you saying, or one of the trigger questions was, what do I do for someone with a different culture or different language? They can't read the label. We're helping to translate that information into a language that they understand. Again, pharmacies should be able to do that. You should be able to refer for the pharmacy and say this person speaks Korean. They need the labels in Korean. Most large chains will do that for every language. And again, asking a patient, you know, what did the doctor tell you about your medicine? What did the doctor tell you to expect? How did they tell you to take it? To make sure they understand by the teach-back method. The next two slides speak to the benefits and risks of a medicine. So how can you help explain some of the benefits and explain some of the risks? And how can you help the client or the participant understand that they're part of the decision-making? What we see in the older population is that they typically don't ask a lot of questions around a prescription. They don't really make their values and their preferences and their goals known, and they don't feel like they're part of the decision-making process. And part of that's because of the short 5 or 10-minute or 15-minute visit. When multiple medicines are prescribed, they don't really understand the benefits and risks. And I think this is where resources come into play. So what resources can you use to help explain the benefits and the risks of a medicine, linking it with that condition, letting the participant know what to expect, and then framing it in a positive way. So what I mean by that is if you're going to explain a medicine to a patient, you have to help them understand exactly why it might be beneficial for them to take this. So in patients with end-stage lung disease and they have difficulty breathing and they're short of breath, what I found is in using a medicine and an inhaler, the doctor's prescribing this to try and relieve some of those symptoms. And it's not something you could just take periodically. You have to take it every day. And so what we see a lot of times, someone will take their inhaler just when they're short of breath rather than taking it every day. So you need to help them understand the benefits of that in terms of helping to control their symptoms, decreasing their risk of hospitalization, decreasing the risk of emergency room visits, infections, and these types of things. So you're framing it in a very positive light, and that helps. Next slide. I won't spend much time on this because most of you are well schooled in motivational interviewing. But again, the concept of motivational interviewing, finding something that the client or participant, you could link it to, framing it out very positively, using open-ended questions, listening and reflecting, responding with empathy, asking what that participant thinks of that information, how it fits in their daily life, and how can we help them change to adhere to that medicine, and then ultimately summarizing that in a succinct way. And then the last 2 points I'd like to make, and we'll kind of open this up, is how do we work as a team in this project? And so a lot of what I've alluded to, you can go to the next slide, next 2 slides, please. One more slide. So the key here is you're part of a team. So some of you alluded to the point where I called a doctor, it was somewhat successful, it was a positive interaction, we made a change and it was positive. Some of the times I've called the provider and it didn't work out. I wouldn't feel bad about that at all. I'd have a very low threshold for involving another team member. I would strongly encourage healthcare professionals to get involved in terms of comprehensive reviews, more targeted reviews. You identify something that doesn't seem right, raise it to the higher level. We're trying to keep these people active, engaged, as functional and healthy at home in their environment and decrease their risk of healthcare utilization. And if you identify something that doesn't seem right around medications, around access, gaps in care, adherence, adverse events, for appropriateness, those are 4 key areas where you could play a huge role. And again, have a low threshold to contacting other people. Involve the pharmacist, call the pharmacy, get a hold of the provider and say something doesn't seem right. I really think because of this, we might need to address this. So I'd like to stop here and say, what other team members do you think would be of value here? And how would you introduce, how would you communicate this? if you identified a medication-related problem that you identified.
Mike?
Yes.
What we'll do, since we are entering the 3 o'clock hour and we do want to have a little bit more time at the end for some questions and comments, we'll have the participants respond via chat. And while they do that, can you highlight some of the resources that are available to participants, families, and their caregivers?
Absolutely. That's a great idea.
Thank you.
So the next slide gives you some consideration in terms of special populations, and then we'll go on to some resources. So I divided the resources into 4 prongs. First is, where can you direct participants, families, and caregivers to get the most reliable information about medications, and that's the National Library of Medicine Medline Plus. They're going to have excellent information in multiple languages, and they'll also have information on over-the-counter products and herbal products as well. So great resource for reliable, credible health information around medications as well as medical conditions. The Health and Aging Foundation tip sheets are very good at saying, how do I communicate with my doctor about my concerns? If I go to visit the doctor, these are the 6 things I should ask. These are helpful tip sheets that are provided by the Health and Aging Foundation that's associated with the American Geriatric Society. So I found these are excellent resources that you can refer family, caregivers, and participants to get reliable information. Next slide. These are tools that you can use. So if your participants are trying to figure out, you're identifying difficulty with medication adherence and how could you improve that adherence, these are guidelines that will give you tips and tools for how you could educate patients on adhering to their regimens. They'll give you medication lists. They'll give you diaries. They'll give you suggestions. And again, these are all supported by organizations that are targeting older adults to try and improve medication adherence, creating master lists, and helping them better understand the importance of adherence. The third set of tools that I was going to provide to you is on the next slide. And these are things that, as a healthcare provider, you have full access to. So the most reliable information you can get on any drug is going to be at the FDA. And you could search any FDA drug there, and they'll have the valuable information written for both the provider as well as the consumer. And then one of the largest initiatives we have in the United States is to screen patients for the highest risk medicines. And so the Beers criteria, the most recent guideline was from 2015, has a list of medications that older adults, the risk of that medication is probably very high. And so they're the ones that are going to say patients who are on certain drugs, we should try to deprescribe them or decrease their dose or try to get them off of this medicine. Now, that's not your job to do that, but you could certainly use that when you identify a drug that's considered high risk, encourage them to have their medications reviewed, okay? And I've given you some data on falls, multiple CNS meds, 2 or more CNS meds. That data comes from the Beers criteria, okay? And the next set of tools that I have for you is just one that I think is a real good point-of-care tool. And so when patients are actually stopping medicines, there's actually a tool that's online that you could plug in that medicine, and it will tell you if it's a higher risk medicine for a senior. So you could download this app called MedStopper, and you could enter a drug. You could enter any drug you want, and that will say if that's a good drug or a higher risk drug, what to expect, what are the common symptoms to see, and is that a high-risk Beers criteria drug? And they do it in the form that it could actually be shown to the consumer in terms of smiley face. Now, again, this isn't advocating that you're stopping medicines. It's just showing that you could put in a medicine to see if it's considered a safer medicine or a riskier medicine in an older adult. And then lastly, I just wanted to share with you that there's a medication adherence toolkit, and that's typically something that I've driven a lot of the discussion today from, that most of the advice and most of the suggestions that I've given you in terms of all the areas that you could help with are really developed and suggested helpful strategies driven by the pharmacist letter and the nurse's letter at medication adherence strategies. So with that, I'll stop and open it up for questions for the group. You go to the next slide just so I could have my take-home messages there on the slide. So what I want to impress upon you is you can make a difference, especially in the area of identifying patients that have very complex regimens, multiple chronic conditions. Consider polypharmacy to be a risk in and of itself, and that medication management is a stepwise and essential approach that encompasses all of your assessments as part of the intake form. When you identify things beyond the scope of what you think you're capable of doing, you just bring it to the next level, whether that's a nurse practitioner, a pharmacist, a provider. It seems like some of you have done that. And then lastly, I want you to encourage and activate the patient to engage and activate in their care, ask questions, make their preferences and their goals and their values known, and the shared decision-making process is instrumental in terms of overall medication management. You could truly make a difference here, and it's absolutely critical that you think of medicines as being possibly part of the problem and not the solution. So hopefully there's some time for Q&A here over the next 15 minutes or so. And if there's questions that are coming in themes, certainly share those with me. Or if you want to open up someone's mic to ask a question directly.
Thank you so much, Mike. That was a great presentation. I know we had to kind of go through the last half pretty quickly, but I definitely think we were able to catch some major highlights. So as Mike said, you are welcome to enter your comments into chat or to raise your hand so we can unmute your line. Alyssa, I'm going to turn it over to you to kind of share what you're hearing in the chat and or share some questions that have been raised from site liaisons based on conversations they're having with their sites.
Sure. I'm just looking. Thanks, Joy. I'm just looking to see if there's anything coming in on the chat. Okay, I'm looking at the questions that are coming in. Mike, it looks like we have a question about from one of our nurses about what your thoughts are on a blister pack versus a pill planner for medication management. I think the question is whether you think there's one or the other that is better for increased adherence.
So it's a great question. I think one of the adherence tools we use is if someone has a confusing regimen or a complex regimen, would an organizer of some sort be beneficial? So, i.e., some pharmacies will put all patients' meds into a blister pack, and they'll say these are the medicines you have to take once a day or twice a day, and they're all in one blister pack, versus putting them in pill boxes. The quick answer is, if you've identified someone that has difficulty managing their medicines, any system that organizes that for them and links that to some daily process that helps them maximize their adherence is going to help. My bias would be blister packs have been very beneficial, especially in situations where the regimen isn't changed very frequently. And so obviously when transitions of care, when people come in and out of a hospital, in and out of the doctor, and they make changes, the doctor needs to be aware that they've got blister pack technology. And so when you switch something, that means the whole blister pack has to be switched out. So there's pluses and minuses to each. My bias as a healthcare provider is any mechanism that's participant specific that's going to help them and activate them or empower them to comply or adhere to the regimen as prescribed would be beneficial versus none at all. And there's a strong movement in the industry to move to blister packs, because exactly for the reason why we saw that happen earlier in the conversation, someone raised the issue where the family, the caregivers were filling up the pill box incorrectly. And so the patient was actually taking the wrong medicines because the pill box was filled incorrectly. And typically those pill boxes are filled in week at a time, and you have to change the whole week if it's wrong. So.
Great, thank you, Mike. So Mike, one of the questions or one of the situations we heard from one of the sites last week was about a resident who was prescribed an anti-anxiety medication, but didn't want to take the medication because they were concerned about the side effects. So what are the different kinds of approaches that the wellness nurse could take with the resident in addressing that, or helping them to address that concern?
Yeah, that's a great question. And so this is where I think communication and motivational interviewing technique comes in. And, you know, the patient obviously went to the doctor and was prescribed a medicine. You have no idea what happened at that encounter, but the result was a medicine, and a medicine that they really didn't understand the benefits and risks, and it didn't seem like it was a shared decision making. So those suggested strategies that I had on the benefit risk side slide and the shared decision making slide are paramount here. So you would have to open up that dialogue to the participant and say, well, I know you had recently been to the doctor, and the doctor prescribed this medicine. What did the doctor tell you it was for? How did they tell you it was taken? What did they tell you to expect? You know, what were you told to expect? Did they communicate the benefits of this medicine and the risk? So for someone like your symptoms, this medicine has been shown to be very effective, and you frame it positively. And so you've got two choices here. One is to help educate that patient on the benefit risk using the resources that you have access to, reframing it in a positive way and communicating that benefit risk. And then, again, you're trying to help that patient who's picking and choosing whether they're going to take a medicine. And so the trust with that doctor around that prescription wasn't effective. I mean, the benefit and risk wasn't effectively communicated, and it didn't take that shared decision-making into account. So the question is, do we report that back right up the ladder to the provider and the prescriber and say there's a disconnect here? They were recently at your visit, and they really don't understand exactly why they were supposed to be taking this. They're concerned about the risk. But again, I think this happens a lot. What we find in the older adult is 1 out of 2 prescriptions that are prescribed are never filled, and 1 out of 2 that are taken incorrectly. And so chances are only 25% of any medicine that's prescribed is ever filled and taken correctly. And so again, it gets to that provider, prescriber, patient relationship, and whether that was truly a shared decision-making and the benefit and risk was discussed. So your role could be enormous at the root level when a new medicine is added to a patient's regimen of helping them understand the role that may play in the benefits and risks of that medicine. And I think
Mike,
a lot of that is... Go ahead.
So what I was wondering was, is it, in this situation, could you do something like, you know, I don't know whether the resident had actually taken the medication and experienced the side effects, or just had never took it assuming they would experience the side effects. Is it acceptable to do something like, say, give the medication a try? You may or may not experience the side effects. You can take it for, you know, I don't know, sometimes you have to take medications for a certain amount of time to have an effect, right? So is it something you could say, we could trial this, we can check in periodically, see how it's working for you. If not, we can, you know, you could talk to your doctor about something else.
I would fully support. I think that I would fully support that. Again, that prescription was prescribed to that patient for a visit. You could say, in the context of that visit, help them better understand benefit risks, and certainly, I think the intent is the doctor wanted you to try that, and if you experience any problems, we'll monitor and we'll manage that and communicate that with your doctor. So again, you're strengthening the trust between the team concept. It's a shared decision. We're all here for your best interest. We're going to keep an eye on it. Remember that slide I showed in the beginning where monitoring was the key, right? How do you educate, activate, and monitor that drug? That's an excellent way you can approach that.
Mike, another thing that that we have heard from some of our properties is we have properties with either with people who have a preference for alternative medicines. Do you have any, I guess, kind of general commentary on that? You said that you noticed a lot of people you didn't see on the list a lot of herbal medicines when you know that that's fairly common. Working with people around who are combining those medicines, or else who don't want to take prescriptions and try to substitute with herbal medicines. I guess that's a big question, but I just am thinking about, we've heard from lots of properties that they have residents who are several properties where they have residents who are interested in alternative medicines.
Sure. I think the issue of, we're such a multicultural country, and there are certain cultures that still practice Eastern types of medicines. And I think the biggest thing from my standpoint is that you have to encourage that participant to be open and honest with their healthcare provider, because Eastern medicines or herbal types of products have drug interactions with prescription drugs, over-the-counter, and supplements. And those drug interactions could be significant. And so there needs to be an open line of communication that these medicines are being used, the typical medicines that we see in an older adult are going to be things for memory, so they may be ginkgo. There might be things for insomnia, such as valerian root or chrysanthemum tea. They might be taking something for their prostate, saw palmetto. So they'll be taking these herbs because their understanding is they're safer than prescription medicines. But actually there's potential enormous risk in those medications because they're not standardized. The formulations they don't have to go through the same process of approval. And so our concern is that, one, the healthcare team is aware that they're on those medicines and taking those medicines. There's been an open discussion and a shared decision around that process. And I'm not saying that they shouldn't be taking them. It needs to be well understood that that's one form of medication practice that they're taking. And if they're taking that instead of their prescription medicines and they're not adhering to prescription medicines, that becomes a significant encounter where you identify that and you need to refer that or make sure that the doctor's aware of that. We found certain communities, certain cultures don't believe in vaccines. And so they don't get any of their vaccinations. And that's a huge area of opportunity for the wellness nurse and the wellness resident directors to get involved in more larger scale immunization education programs and focus groups around the value of vaccines. So.
Okay, great. And I'm just, as I'm listening to you, I'm scrolling to see if we're missing anything in the chat, and I see an example that one of our sites listed that kind of speaks to this potential interaction of not being fully disclosing everything you're taking. In this situation, they said their wellness nurse had noticed that a resident had just started taking Eliquis and was still taking a fish oil supplement. The wellness nurse called the resident's PCP, who was unaware the resident was taking the fish oil, and there was a potential adverse effect from combining those two, apparently.
Yeah, and I don't think we're going to have all the answers for sure. The fact that the wellness nurse did exactly what they should be doing. That on the master list, there was a medicine that was added, and the doctor or provider that was prescribing the drug might not have been aware that the patient was also taking other medicines. So this is part of that master best medication list, and if you've identified something, it's very important that the patient share that with the provider, or you share that with a provider, or have that patient, encourage them to take advantage of the medication review. You have a right as a participant to have your medications reviewed when you go to see your provider. I'd encourage you to bring your master list, or actually bring your medicines to them to make sure that there's no drug interactions and you're on the best medicines for you at the right doses, et cetera, et cetera. So that was very important that the wellness nurse brought that to someone's attention. If we look at medicines that create the biggest problems, they tend to be diabetes medicines like insulin and oral drugs for diabetes. antiplatelet and anticoagulant therapies like the IWISH, right? So drugs like aspirin and Plavix and warfarin and apixaban, these types of medicines are the highest risk medicines. And then the third class of compounds that are the highest risk of medicines are meds for sleep, insomnia. These are the ones that create the biggest problems for people coming into the emergency room.
Thank you. Alicia, if you don't see anything major in the chat, we'll go ahead and wrap things up. Is there anything major you think we need to talk about before we close out?
I see there's one last question coming in. So if we could just get this in because Mike has been referring to this. We have a question that asks, how is a medication review by a pharmacist initiated? Is it through, yes?
A couple different ways. The first step really is just identifying a person you think that would benefit from a medication review, and then referring that person back to their provider and saying, you know, you have a right to have your medicines reviewed when you go to see your provider. And that provider ultimately will review those medicines, and they may do that themselves, or they may do it with a nurse practitioner, a PA. They may actually have a pharmacist embedded in their clinic. That's the first step. The second step of a med review by a pharmacist would be kind of aligned with that, and they could align that with the provider where they get their medications filled. So pharmacies can take a review of those medicines and work with the doctor for them. And then, believe it or not, the third way that this is aligned is insurance companies are actually doing this behind the scenes. So believe it or not, patients' medicines, or I should say participants' medicines, are being reviewed by an insurance company if they're identified as high risk to begin with. And so behind the scenes, that med review is actually being done in certain populations, the high-risk populations. So the best way that you, as a wellness nurse or a wellness resident director, can get involved is either encouraging them to communicate with their pharmacist that they go to fill their meds, or directly with their provider. Okay?
Mike, if their insurance is doing a review, are they if they find any problems, do they then contact their doctor, or do they contact the insuree directly?
The answer to that question is both, but they're primarily working with a provider. So anyone under CMS Medicare, the regulation that people with complex regimens that have polypharmacy and high-cost medications, they're being reviewed by a pharmacist behind the scenes, communicating with the provider, and they may actually be sending some communication to the participant to say you need to bring your medicines and have them reviewed by your doctor. So don't feel like that you're intervening. Don't feel like you're superimposing yourself incorrectly. If you identify a high-risk patient or cohort or participant, this whole process of medication review should be dealt with and addressed, whether it's going to be dealt with at the pharmacy level, the provider level, or the insurance level. You just need, when you identify concerns, you need to activate, educate, and empower the patient to make them aware that there's risk with medicines, have those meds reviewed.
Great, thank you.
Thank you, Alyssa. Thank you, Mike, so much for those great answers, and thank you to our audience for asking those questions. Even though we are rounding up, as we said before, we are here to help you. We are here to help you gain the resources, the tools, the knowledge that you need to best serve your IWISH participants. So if you have any questions that were not answered, any lingering thoughts, feel free to reach out to the implementation team, and we'll be happy to connect you with Mike and answer your questions.